Hello, I'm Norman Swan. Welcome to A Big Ideas, where we're going to ask the question, can we save healthcare? What could be more important to any of us than our health and well-being and that of the people we love? And in Australia, we're lucky where we have a health system which, when we're sick, makes us better, irrespective of our ability to pay. Well, at least that's the theory. We Australians pay more in cash out of our pockets that's not reimbursed than almost any other country in the world. Public hospitals are bursting at the seams. Private health insurance premiums keep on going up. General practitioners, the foundation of the healthcare system, have had their fees frozen for a few years, and they continue to be so. We pay for procedures, tests, and doctors' visits rather than care and good outcomes. We're one of the fattest nations on the earth, and that could topple us from being near the top of the league of long-lived nations. So, is it all going to crash around our ears? And can Australian healthcare be saved? To discuss this and to answer that, we're going to try and apply business thinking to these problems. Under the auspices of the Business Council of Australia in association with Australian Unity, we've gathered some of the people who run and fund the Australian healthcare system to see if we can actually get to some new thinking. Can we actually use business thinking to break new ground? But let's never forget that healthcare is about people. People who are often angered and perplexed by the system and wonder why it isn't run like other businesses. One of those people is Carl Fender, who's an architect. He designed the Eureka Tower in Melbourne, one of the tallest buildings in the Southern Hemisphere. He's designed art museums. And one day he took his wife, in excruciating abdominal pain, to the emergency department of a major Melbourne teaching hospital. They kept her for 3 days, saying she had gastroenteritis. Delirious with pain, she discharged herself and then ended up in a private hospital soon after, where they correctly diagnosed a burst appendix. Here's Carl's story.
I was told that the operation was a success, but there may have been a complication. They were waiting for scans to tell us whether she had had a stroke. It was then explained to me that the anaesthetist had injected into her neck, missed a vein and hit an artery, and that this caused basically a stroke, which was shocking to say the least. My wife has to deal with certain issues on a daily basis. Her left side is always in pain, she's always rubbing it. She's blind on the left half of her vision cone. She can't travel by herself, she can't drive. We decided that what had happened to her was not acceptable, and we decided to pursue it through the legal system, if only to bring attention to it and hopefully just help in one small way for this not to happen again, because those mistakes could have been avoided. It could have been avoided in the first hospital by them being more thorough in their investigation of what was wrong with her. And in the case of the anaesthetist, if an ultrasound had have been used to help direct that injection, which is common practice, then that could have been avoided as well. It seems to me that in the medical profession, as soon as a patient walks out the door, any responsibility, it's kind of absolved. Certainly in our case, the people that were responsible for making the decisions or not making decisions or whatever just got buried in a big medical system. And okay, you know, I was apologised to by an anaesthetist, but when he left, that was the end of it. He got on with his life and we were left to get on with what was left with ours. The hospital absolutely bears responsibility. And if that hospital's held accountable and it costs them money, then maybe that's an incentive for them to use everything at their disposal, equipment-wise, to minimise the possibility of things going wrong.
Catherine Livingstone, President of the Business Council of Australia, Chair of the Telstra Board. You've also had a major role in the medical industry in Cochlear, the bionic ear company. There's no way to run a business, is it?
Well, Norman, absolutely not. I mean, in business, we look at the customer and the experience of the customer and the whole experience of the customer as affected by whatever we do in business. So not putting the customer at the centre, as has just been described, is just totally unacceptable.
But you know there's challenges putting the customer at the centre of the Australian system.
There are huge challenges, but that doesn't mean that we don't start and try. And you start with sort of basic principles. You don't try and solve the whole problem, but you can start with some very basic principles and keeping the patient informed. And I think this is one of the things that we see when you're a patient in the system. Trying to get information about your own circumstances is extraordinarily difficult.
Deb Piccone, you run the Australian Commission on Safety and Quality in Healthcare. It's either the second or third version of such a commission we've had in Australia. So we spent a lot of money trying to get safety in the Australian healthcare system. How come we still hear stories like this?
If you were to compare health to the mining industry, and I met a leading miner a month or so ago, and he said to me he couldn't understand what he viewed as a rather cavalier approach of the healthcare system to safety when the number one issue in mining, as it is in air transport and other major industries, is safety. And I do believe the health system has a long way to go. It's interesting, we know more about the occupational health and safety of the staff than we do about the patients.
Solutions?
The solutions are to continue the work that we're doing on developing the safety systems to be implemented into the hospital.
But you don't police them, you just set the standards and hope for the best.
They are policed through an accreditation system.
So I'll come to George Savvidis. You don't think they're necessarily well policed. You're Managing Director of Medibank Private, and you've been cracking the whip with private hospitals on this and creating a financial incentive for them to become safer.
Well, that's right, Norman. At Medibank, we hear the voice of the customer and their concern about quality and safety, and that's understood in health insurance. Immediate access, better amenity, doctor of choice, so they're very important variables. But in the hospital experience, in our claims data, and we have about a sixth of the population insured with Medibank, there is a material amount of costs consumed with highly preventable complications in hospital, and we're able to track that and measure that. And in more recent times, we've now moved that knowledge into our contracting with private hospitals to hold them accountable for complications, things that go wrong.
So they suffer financial penalties if things
That's right. We're in our new contracts, we're saying we're not paying for these failures because we don't want to give you a perverse incentive to think that you can continue doing this, even though people don't deliberately do this.
They make more money out of complications.
Well, it's not appropriate for our members to see us pay for things that go wrong.
But you've had pushback.
Oh, we've had a bit of pushback, but we've also had, to date, 151 hospitals signed up to these high-quality performance-type contracts with Medibank, and they are putting shoulder to the wheel and doing the cultural change that we saw the mining industry and the industrial sector do over 20 years ago.
And this is one of the issues I want to cover today. Have we got the wrong incentives and disincentives in the system? So you're saying that when you put a financial penalty in, you get change?
Correct, but if you focus on the measures and you provide a link in terms of health funding with those measures, people will improve to avoid the penalty.
So when you say measures, you accurately measure the errors and injuries that occur in healthcare?
We list out the claims items that are associated with highly preventable events, and we use those measures to guide the process of what we won't pay for.
So you've got better data about the customer than the healthcare system, don't you?
We have a lot of really good data now. We have a strong data and analytics team. We can now measure unwarranted variation, we can measure over-servicing, and in some minor cases we can also detect fraud.
We'll come back to some of those issues later. We've got on tape one of the world's leaders in thinking about healthcare and healthcare reform. His name is Don Berwick. He was the founder of the Institute for Healthcare Improvement in the United States. He's consulted widely internationally to the UK NHS, has been to Australia many times, and more recently was chosen by President Obama to run their huge public reimbursement systems, Medicare and Medicaid, for people who are poor and disadvantaged and the older community. I asked him to define what he thinks the problems are in healthcare.
The most significant problem is fragmentation. We built healthcare systems historically not as systems, but as pieces. Hospitals, physician practices, laboratories, emergency care, nursing homes. And we never addressed the enormous potential of working seriously on prevention and public health. So we built a system in pieces. When a system's in pieces, it cannot function at its highest level of possibility. We need an integrated approach, and it's been that gap that's cost us so dearly. It's resulted in lower health status than we should have, certainly in developed nations, many errors in care and injuries to patients. It's made patients and families feel distanced from care, so they've lost a sense of autonomy and agency. And we've added costs. The costs of a system not built properly are enormous, and every country is feeling that pinch as healthcare really takes resources from other productive uses. And healthcare occupies such a big space psychologically and economically in societies that when it doesn't function properly, it bleeds resources. It takes resources. I say it even confiscates resources from other uses. When the funding is public funding, then that money's coming out of education and transportation and social justice and enterprises government should have its money for. And on the private side, when healthcare costs too much, it erodes the competitiveness and the vitality of private industry. And probably most of all, it takes money out of the pockets of workers. I would estimate at least a quarter, maybe as much as a third of what healthcare absorbs in resources in most Western countries is waste. It's overuse of things that can't help people. It's failures of coordination. It's errors in care that cause injuries, that cause other costs. It's administrative burdens that erode the productivity of the workforce. It's pricing failures. It's a failure of thinking about resources other than healthcare that can meet needs, where we're using the wrong tool to achieve health. Add all that up and other kinds of waste, I would say a quarter to a third anyway of almost any country's expenditures today, at least in developed countries, isn't helping patients.
Christine Bennett, you're now Dean of the School of Medicine at the University of Notre Dame, but you did, for your sins, chair our last major national process of health reform. You must be sort of grinding your teeth listening to this, that nothing's changed.
I think Don's really hit the nail on the head there with fragmentation. One of the things we heard most commonly in the work that we did a few years ago was that people can't actually get in to see their GP, that the out-of-hospital care for someone after a stroke, after a knee replacement, waiting to get into a nursing home, or indeed just day-to-day issues, how do they get that primary care? And if they do have a complex and chronic health issue, they might have multiple different professionals, different specialists, different allied health professionals helping them. Navigating the system, gluing that together, understanding what the right care is at the right place at the right time is overwhelming for so many people. So I think from a person point of view, who pays and who delivers means that it isn't connected together well for the person.
Martin Bowles, you are Secretary of the Department of Health in Canberra, the national bureaucracy, if you like, that manages policy overall, and part of this fragmented process where the demography of illness has changed, where we've got a system designed for individual episodes of acute illness, when people now have long-term illnesses that last for a long time, they never get better from it, and they need continuous care. Yet you, through the Medicare scheme, is funding episodic care, bits and pieces. And you fund GPs, but not hospitals. The states do that. Is this going to be the same forevermore?
Well, Norman, it can't be the same forevermore. I think this is one of those unique opportunities we have. Today is an example of that, where we've got a range of people with different backgrounds that can talk about the system more broadly. What Don was saying about a fragmented system is right. I'd go one step further and say it's fragmented but disconnected in a whole lot of ways. And I think what we need to start to do is to think about this as a health system, not component parts. Because that's largely what we constantly talk about. And if I was to be quite blunt about the characterisation of health in the media, it's about hospitals. It's about public hospitals. Yet it's less than half of the system. It's about a third of the system. We do have the GPs, as you mentioned. We do have specialist activities. We do have the private sector. So we need to start to link a whole range of these issues together as a system. And what we've started to do from the Commonwealth perspective is to think quite strategically about how does the system start to link. My kids used to say, are we there yet? Well, the answer is no, we're not, but we are on the journey. We've got a range of activities happening at the moment. We are looking at the medical benefits schedule. We're having a look at appropriateness of activity. What is low value? But also, what are things that we should be doing that we're not doing? We're also looking in the primary care space. In particular, you mentioned chronic disease. It is the fastest growing issue that we have to deal with. 50% of the population have at least one chronic disease. 20% have 2 or more chronic diseases. We have to change our system to really deal with that, but underneath that, not only our models of care, but our funding models.
So that sounds fantastic, Martin. Yet, in Scotland, I understand, if you actually want data that Catherine's talking about the customer, you make one application on one form and you get access to the data on individuals so that you can feed back data to the system. I constantly meet people who've got National Health and Medical Research Council grants where the grant has run out before they've got access to the data they need to do research into improving our healthcare. The privacy, the privacy lobby has taken over. We're so fearful of privacy, and politicians and bureaucrats so fearful of it, we don't get the data which we already have to deal with the system.
Well, I have a slightly different version.
Well, you're not surprising me to say that.
I'm not surprised that you're saying that, but I do have a different version. Look, I absolutely am one of the great believers that we have to put data and analytics at the centre of our system. We have some of the richest health data in the world in this country.
Locked up.
Well, part of my job is about how do I start to pull that together. I think we've traditionally had ownership model around data in our system, and I think that has to change. So we do have to look at this in a different way. What I've done, for instance, in my department now, I've started to pull it all together. I'm bringing data, analytics, evaluation and research into one particular space, which is going to advise the strategic policy part of my department. We've actually opened up the access to the PBS and the MBS data. We've given it to the states and territories.
So just to explain here what we're talking about, that's the pharmaceutical benefits scheme where you write out scripts, and the medical benefits schedule, which is what your GP and specialist can claim for against a certain 5,700 odd items.
That's right. Sorry about acronyms. That's one of the risks in health. But we have opened access to that data up now. We've given it to the states and territories. I'm a great believer that we need to actually look at data and find out what is truly private to me, what can be shared, but also what is open. What should we actually give to the researchers? What should we give to people out there who can make a difference with the data that is out there? So we're on that pathway. But it's not as simple as flicking a switch, because if it was, we would have probably done this many, many years ago.
But there are some switches that could be flicked.
There are.
If the legislation was right. Rowan Mead, you're CEO of Australian Unity. You're chair of the Business Council of Australia's Healthy Australia Task Force, which is really the auspices of this meeting. But is the private sector part of the problem here? I mean, it's yet more fragmentation. So we've got the Commonwealth running general practice and things that happen in the community. We've got the states, which run public hospitals and other things as well. And we've got the private sector. I mean, it's just fragmentation wherever you look. Are you part of the problem?
I think every part of what you describe is part of the problem, but I defy the characterisation as, some sort of wand that suggests we remove one piece of fragmentation, we'd somehow or other address the system's issues. Far from it. I mean, what we're talking about when we're talking about fragmentation is fragmentation of incentives as well. And if we're going to actually start to think about the consumer and being responsive, I would argue that, in fact, the private sector is at the forefront of some very key initiatives in relation to actually joining up the care in service of the consumer, in service of the patient. Yes, are we part of the problem because we don't have sufficient scope of information? You were just talking to Martin about data and analytics. We have some rich and valuable data that we are starting to put in service of the customer and their needs. But its scope is relatively narrow. It extends to our experience and our view of the healthcare system in acute hospitals, claims patterns, ancillary claims patterns. I would suggest that the private sector is making fantastic progress at joining up that data in service of the patient. However, there are still pools of data, fields of data, that are not available to us.
But you've
For
got
example, primary care.
But you have some structural issues. Specialists who tap into private health insurance in private hospitals feel that they've got much more freedom to operate than they do in, say, the public hospital system. What's called clinical governance, where actually what they do that's monitored in some private hospitals is not as well monitored as it is in some public hospitals, and plenty of public hospitals fail as well, as we just heard. People who subscribe to your subscribers, your members, think they've got an uncapped system that they can actually get whatever care they want. That's why they've got private health insurance. I mean, there's lots to be done in the private sector.
There's enormous amounts to be done, Norman. What we've got as a healthcare system, essentially, is a piecework system that rewards volume and activity, not outcomes and patient good and well-being. Let's start talking about that problem, and let's address that set of circumstances. And I think in that particular scenario, the private dimension has enormous experience to offer in how to be responsive, in how to orientate systems towards their end consumer.
Let's go now to Sir Muir Gray. Muir Gray used to be called Chief Knowledge Officer of the National Health Service in the UK. He was one of the founders of what's called the Cochrane Collaboration, which is an international collaboration of researchers which pulls together the best available evidence for healthcare. And he spent a lot of his career trying to put that in the hands of consumers. And his current task is actually to shift the British system towards what he calls higher value care. Muir Gray.
As you put more money into healthcare, you get the law of diminishing returns. So the benefits go up steeply, and then they flatten off. Unfortunately, in healthcare, the harm goes up in a straight line. And it means if you subtract harm from benefit, you get a J-shaped curve. And there's a point of optimality. And when I'm on the road, speaking in town halls and with clinicians, I ask, give me examples where we've gone beyond the point of optimality. And the public and the clinicians, what they come up with are things like chemotherapy in the last week of life, or people aged 85 plus dying in intensive care. The way we are at the moment, and I know a little bit about Australia, the way we look at things at the moment, I'm sure someone could tell me exactly how much is spent on every health centre, on every hospital, but not telling me how much is spent on either a simple problem like chronic obstructive pulmonary disease or epilepsy or atrial fibrillation, and there's about 100 problems like that, or complex problems like the last year of life. And this requires someone to say, well, what business are we in? And they say it's like the supermarkets. You see, every country you go into, you can see the same aisles: cardiovascular, respiratory, end-of-life care, elderly people with frailty. And as you walk down the aisle, you see the same bays: beef, pork, lamb, asthma, COPD, sleep apnea, psoriasis, eczema, acne. But what we've got at the moment, and I see it in Australia too, people just talk about the turnover of the supermarket as a whole. Oh, we did $500 million last year. Yeah, but what was it? Was it meat or fish or children's clothes? Well, I don't know. So I'm using the supermarket analogy quite a lot. And again, what we produce these atlases, not for information, but for emotional impact, to destabilize the medical profession and the people holding the budgets, to say, you know, this is, I don't mind what your specialty is or who you work for, but look at the variation here. Variation in everything: access, investment, quality and outcome. But we need to move on from quality now. Quality is necessary but not sufficient. You can have high quality, low value healthcare. Quality is important, but tomorrow's agenda is value. This is moving from bureaucracy-based healthcare to knowledge-based healthcare, where knowledge runs the program. What bureaucracies are hopeless at is dealing with complexity. So if you wanted to improve the care of people with macular degeneration in New South Wales, try to do it through the bureaucracy, chief execs writing to other chief execs and joint working parties, we have to have an adaptive system approach, namely you get all the people in eyes and vision together and you say, including the patients and the carers, and say, ladies and gentlemen, boys and girls, there is no more money. Now let's sit down and talk. Let's design a system of care for people with macular degeneration. Bearing in mind, we've got to think of the people with glaucoma and retinopathy and cataract as well. So it's a different approach. Bureaucracies do one thing, complex adaptive systems do another. So don't change the bureaucracies, don't reorganize the structure. Get people working together in floating and using the internet in parallel to the bureaucracy.
Adam Elshog is Associate Professor of Healthcare Policy at the Menzies Centre for Health Policy and an international authority on low-value care. Is Muirgray's prescription for moving to high-value care the right one?
Norman, is the only way forward, as we see it. The 30% waste figure in healthcare has been bandied about quite a lot, and that work actually comes out of the United States and the Institute of Medicine. That 30% waste figure is actually broken down into multiple categories, everything from fraud to administrative complexity, inappropriate care, low-value care. We simply don't know what that number is in Australia. We suspect it's somewhere in the order of 20 to 30%, but the metrics still need to be worked through. And as we sit here today, there is really a paradigm shift occurring in data. It's the big bang of big data, if you like. And that really is going to be driving the future of healthcare. And the reason that's interesting is because if you think about the last 30 or 40 years of healthcare, as we've spoken about today, the remuneration has really just been driving volume. And now what the data is telling us is that, in fact, we should be paying for quality. So there are two groups. Those groups who are pushing back on the data revolution, and that's because they're afraid of the punitive nature that they see data could bring. But then there are groups who are adopting the data, and they're saying, well, actually what the data is doing is it's telling us where there is quality, and we want to focus on that quality, and we want to minimise the waste, and we're going to get paid more for doing better. And I think that's now the future. We need to encourage those groups who are slow adopters of data to move ahead of the curve, to identify and capitalise on the value.
But Muirgray's fundamental point there at the end was you're not going to get anywhere unless you put the patient in the room, the consumer in the room, and make them truly the centre, not just some token, docile patient who's almost pathetically grateful to be there, but somebody who's bolshy and draws the complexity towards themselves.
Well, the information being available is key to that. So the Choosing Wisely campaign, which is rolling out in Australia, the fundamental premise of that is actually to encourage a conversation between doctor and patient around the role of potentially inappropriate care. So there is a bit of a revolution happening, and doctors are at the forefront of that movement. They're recognising that they want to engage their patients more around potentially
in a pretty namby-pamby way, one would have to say. They've chosen the low-hanging fruit, and they're all saying, well, the problem's over there, it's not here, don't blame me. It's always the GP that they blame.
Some groups are doing that. Other groups have been much more forthright in owning their own problems within their specialty.
But it's still within that episodic system where we've got a system designed for just seeing a doctor, not for making you better. So you're going to have all the data, but not the financial incentives in place to actually get results, whether it's the private or public sector.
You're quite right. So we have an interest at the University of Sydney in looking at alternative payment models that are being used internationally, so including from the United States and parts of Europe, where you move away from that episodic payment to more bundled payments or capitated payment models to see whether or not the resources can actually be spread over longer periods of care rather than the episodic nature. And we think some of them might have direct applicability to the Australian system.
Stephen Duckett, you head the healthcare group at the Grattan Institute in Melbourne. You have run the Commonwealth system, a state system and a Canadian system, and have so a passing interest in this. Do you agree with Adam's analysis or indeed Muirgray's?
I certainly think that we need to engage the consumer more in having more information about what the likely outcome of their treatment is. And so, for example, if I go into hospital tomorrow for a hip replacement, I've got no idea whether that hospital has a higher rate of adverse events or a lower rate. I've got absolutely no idea where on average in that hospital my pain is reduced more or less than other similar hospitals doing hip replacements. And so there's a lot of information that consumers would like, which they don't have, and in fact the system doesn't have. And so we really need to be focusing on getting more information and using that information to measure value in the health system and to do something about it.
But what about the radical notion that the patient is actually the key person in the redesign of healthcare? And that's that point that we made right at the beginning, is the one big difference between healthcare and other businesses is that we really don't put the customer, the consumer, at the centre.
I think that's partly true. I think we've got to put the customer, the consumer, the patient at the centre, especially for a person with chronic disease. They live with it 24/7, their carers live with it 24/7, and so obviously they should be in the centre of whatever we do. But we also have providers who have to be engaged in the system as well. At the moment, we've probably overemphasised the provider contribution and underemphasised the consumer contribution. But I don't like the idea that it's either or, it should be a both and.
Partnership.
Yes.
Sounds nice. Getting close to kumbaya, but let's see how we go. Fran Diver, you work in the Victorian system at a senior level. You know, it's been highly variable, the extent to which systems have actually centred around consumers. They all talk about it, but don't necessarily do it.
So I take the view that clinicians turn up every day to go to work, and they turn up to do the best they possibly can. So I actually think that...
So you're saying the system is what mitigates against doing the good job?
I actually think people working in the system are looking to do the best they can, but what is it about that we've put around the system to support them to do their work?
Well, you're responsible for one very big system. What are you doing about it?
So this is our daily task. I think reforming the system is what a lot of people are focused on, and we've said it's a big complex system. And I guess the issue is, do we do incremental reform or do we do a big revolution? So we can do evolution or revolution, and I think there are times, very rarely, where we get the chance for a big revolution to make a significant change. I guess I also take the point that's been made, which is don't keep reorganising ourselves, don't keep doing structural reform. So I guess in Victoria, our approach has been to try and put as much flexibility in the hands of the providers and consumers where we can, so on the front line, but also put adequate accountability and regulatory arrangements to ensure that patients are actually getting the best deal they can.
We often talk about doctors being the resistant group here when you bring consumers in the room. But I've seen the healthcare managers being the really resistant group, because they've got their own fixed ideas top down of what should work, and really just pay a token nod to the sort of flexible adaptive system that Muir Grey challenges us to pick up.
I think there's resistance at every level, at bureaucracies, at providers, clinicians, and at consumer levels as well. So I think there is a need for a conversation about change. But I think we've got enough change agents in the system to keep doing incremental reform. The question is, are we going to do a big step change through some revolutionary reform? And are we going to lose some of the opportunity on the way because we're busy reorganising ourselves?
So the question here is disruption going to actually do it for us and basically ignore the system and get on with it? Are new technologies coming around the corner which will say, well, look, we'll leave them to do their job, but actually the community is going to be streets ahead of where the healthcare system is because of adaptive technologies? I spoke to somebody who's been watching the digital revolution in healthcare quite closely. He has a large following for his thinking. His name's Paul Saunier, and where else would he live but Southern California?
The disruption that I see happening in healthcare, a lot of it is not so much within the boundaries of the healthcare system, but we're also seeing it on the outside, where consumers are being empowered with digital health solutions to better manage their health, prevent disease, and live better lives. Fitbit has sold upwards of 20 million devices globally. You're seeing payers use these for patients, once they're discharged from the hospital, to help monitor them in their recovery. People do end up discarding these, so to speak. But when you transition to other wearable tech, like the Apple Watch, which is a multi-function device, a smartwatch, as we call them, you see the adoption rates go up. I just saw a survey that somewhere around 86% of Apple Watch users surveyed indicate that they get a positive benefit on their health from using the device. So this is this ubiquitous wearable tech, I think, where people actually wear the device, because not so much for fitness per se or medical reasons, but because they have it for communications, convenience, productivity. I think that's where we're going to see that sort of subtle stealth health aspect coming into play with wearable tech. I think the best example of devices and technologies, we could point to the Qualcomm Tricorder X Prize, which is essentially a $10 million prize to bring a Star Trek medical tricorder-like device with diagnostics and biometric monitoring directly into the home of consumers, patients, and essentially bring that continuous monitoring and as-needed monitoring of patients/consumers outside of the hospital. So I think that disrupts the traditional business model of the healthcare system. I think we're sort of at that inflection point for this to scale, and I think perhaps that is the operative word, is that once we achieve scale is when we'll really start seeing the impact beyond just prevention, but also cost avoidance, where people can manage their health at home a little more effectively and reduce the impact on the healthcare system. Like Cedars-Sinai in Los Angeles has already turned on a feature in their Epic EMR, EHR, so that the heart rate data from the Apple Watch can go in there. And so you don't have this sort of one-time only biometric, but you can look at it over time, and the physician can have insights into the patient a little more detailed and coach them, so to speak. I think healthcare will become more on-demand and predictive and preventive. You get to the point where the healthcare system is more proactive in treating patients, and it's more convenient for the patients. And you're using less of the brick and mortar infrastructure and more of the digital infrastructure to promote better health and manage chronic conditions much better.
Shane Solomon, you're Managing Director of Telstra Health. Sitting from the outside looking in, you seem to have been given a brief or taken on a brief to disrupt the healthcare system with new technologies, and you're buying up companies. I'm told your KPI is earning $1 billion a year for Telstra out of this enterprise. Is he right? Is Paul Saunier right that there could be a leapfrogging here? We were sitting talking in our slow way about change, but technology is going to do it for us.
He's absolutely right, and he's only telling half the story. The potential, if you think about health as a market, what's wrong with our market? What's wrong with our market is the consumer is disempowered, which is strange because the consumer is the one that cares the most about their health.
And before you go on, I should tell the viewer that, in fact, you've run the Hong Kong health system, you were deputy in charge of the Victorian health system, so you know a bit about running health systems.
From the other side, yes. And I think on that, the biggest, if you look at digital disruption, something that's easy for the consumer, good for the consumer, and cheap for the producer, or cheaper for the producer, is irresistible, and that's what's happening here.
So what's the other half of the story?
The other half of the story is that that what we know is that if people do manage their own health, particularly those very heavy users of the healthcare system, you reduce hospitalisation by 30 to 60%. And that's being proven around the world with the sort of technologies that he's talking about. But we're looking at telemedicine. Kaiser Permanente, big health insurer in the States, does 50% of its consultations now online. So the need to even physically see a doctor as well as physically go to a hospital, is being undermined. In that sense, there's a bit of Uber about this.
And you've acquired an online consultation business.
We've set one up, actually, in partnership with a Swiss company.
So does the business model exist, though, to fund that disruption? Or you're relying on people to pay for it out of their own pockets, which I think is the case with your online consultation company?
Well, I think what has to happen is you need to prove the technology first, prove the service model, prove it's safe, prove it's effective, prove it's popular. And I'm very confident that the funding system catches up with that. I'm also very confident that people are willing to pay money for their own health. If they gain an advantage themselves, if it saves them 5 hours or a day, going to the doctor, coming back, then I think there is a willingness of people to pay.
What about the disadvantaged? We know that there's a digital divide. We believe in fairness in Australia. We have a universal healthcare system which provides healthcare irrespective of ability to pay in theory. Does this not jeopardise that universality?
Far from it. I think one of the issues that we're confronting is that people in, say, rural Australia have terrible access to GPs. So this actually opens up that access. I think what payers are looking for are new service models that are good for the consumer and good for them. And that's what we're about, creating those service models, and then hopefully, they're made available more widely, more equitably.
Sam Prince, you're a doctor, a medical entrepreneur. You've got startups working with disadvantaged Aboriginal communities, as well as in biotech. What's your view of this disruption story?
I think it's an exciting time for technology to kind of change the landscape. And I think as we kind of work in the kind of free markets, it's innovate or perish. However, I also kind of see the relationship between kind of patient and doctor as a sacred one. And I think that it's analogous to kind of...
So is Shane Solomon being sacrilegious then?
My relationship's not sacred, so... And I don't want to interrupt, but I think that's the fundamental issue, is for some people it isn't. But for many people, it's a transaction. I want a drug. Diagnose me, can I have the drug, please? So sorry.
That's okay. I guess I still see it as a sacred relationship, and almost analogous to kind of a marriage that is very, very, very long, and perhaps an elderly couple who were married, 40, 50 years ago, perhaps when equality was not there when they were first married, and there was a paternalistic view, and over time liberties are taken and a relationship becomes unbalanced. And I think I see technology as a really good reason to redo our vows now and look at our marriage continuing on, where a relationship can be kind of more equal.
Fran Thorne used to run the Victorian system, consulting, but also known as, a tech lover and interested in this area of digital disruption.
Yes.
What's your take on it?
I think there will be a lot of disruption happens, and I think it's going to be a good thing. Like Shane, I'm not sure that we all have a sacred relationship with our GP or our specialist or even our hospital. So anything that enables people to make different choices about how they access healthcare is going to be really useful. The thing that...
But if I can just pick you up on that, I mean, the conversation there was very transactional. But for the 1% of people who consume 30% of the healthcare budget, they don't want transactional healthcare. They want continuous healthcare from people they know and trust.
Absolutely, they do, and I was going to turn to that group. What I think is emerging is the more and more we know about people's health and the capacity we have to use data to really target how we interact differently with different users of the health system is something we've not really tapped as well as we might, and that will include much more intensive sets of arrangements that we put around people who really need integrated care. That also includes use of data about clinician practice. It's astonishing to me that in this country we still think it is okay for no one, we don't think it's okay, but there is very limited questioning of the fact that many clinicians continue to do things that we know are not particularly useful. And as part of the use of information and technology to bring disruption to the system, we have to look at it from the consumer side and from the clinician side so that we can improve the balance between the patient and the clinician about knowledge of what is going to work and what isn't going to work.
Jennifer Westcott, CEO of Business Council of Australia. Traditional business has not been good at dealing with disruption, pretty bad in fact. Why should healthcare be any different?
Well, this is a challenge for the whole economy now. I mean, the consumer is going to be the innovator. They're going to be, we talked about fragmentation, they'll be the integrator, and they'll probably be the regulator. And businesses, government services, health in particular, is going to have to chase that model. And businesses have had to chase that model. Banks have had to chase that model. They originally started dragging people to the ATM. Now consumers are taking them to mobile banking. So this is how we've got to start thinking about how do you design a system, a complex system around a very, very empowered consumer on one hand, some very disempowered consumers on the others. How do you get the system to be agile and nimble enough? And how do we start to move to a kind of shared care? It's not one or the other. How do you start to bring that relationship together where the consumer and the medical practitioner are working together on that shared care? But this is a very, very disruptive phase, but it's a good disruption, and it will, I think, create a business model that is far more fit for purpose.
Let's go back to Don Berwick to hear what some of his solutions are.
Well, when we make people helpless in care, put them in funny-looking hospital gowns and tell them to listen up, and we do all the talking, or when we talk Greek and Latin around them so they can't understand what's happening, we enter a vicious cycle. They become more dependent. Because they're more dependent, they have more expectations. Because they have more expectations, we do more, and so on and so on. And we build this activity that isn't really helping because we didn't listen in the first place. And what we know from high-performing healthcare systems, we don't say, what's the matter with you? We say, what matters to you? And we orient our efforts toward that. Respect the particular values and conditions of every individual. You get better care. And then beyond that, think about prevention. We know from science that when you look at variation in health status, healthcare accounts for about 10% of that. But more than half is accounted for by things other than healthcare that we can change: nutrition, exercise patterns, substance abuse, social justice, the elimination of poverty, racial justice, gender equality, all of these things, environmental stresses, these have a lot to do with our health. Well, those are in the control of the people. And if we began to reorient our thinking about investment in investing in the actual things that cause or lead to illness and deficits, we would change how we spend our money, and we'd help people help themselves to stay healthy. That's what power means. It's control over health. The great scholar of modern quality, one of my mentors, W. Edwards Deming, once said, I heard him say, the customer, in this case the patient, has no expectations that the producers did not create. If we have a public that thinks that the next MRI or the next procedure is going to save them when it won't, we created that expectation. We can unwind it. And there's one other kind of tough fact here, and that is that if you actually look at the economics of this, in many healthcare systems, I'm not sure about Australia at the moment, the economics drive use. That is, the producers of care make more money when they do more things. And so that engine of constant increase in activity, that's being produced by the way we're paying for care. We pay for procedures and processes, not for health. If we were to change that, I think more common sense would enter the system. I'd say a truly person-centered healthcare system will almost inevitably be far lower cost than one that's controlled by technocracy and the myths of the past.
Alan Fells, you're a professor of government at the Australian New Zealand School of Government in Melbourne, but you're also chair of the Mental Health Commission. This has almost been a life career for you to actually put the person at the centre of the system. And you're still agonising over it. Major review of mental health care showing it's still not happening. So is this just whistling in the wind by Don Berwick here?
Well, I think all politicians will respond to the fact that there is a very big mental health community out there. 3 million or so people are affected, and for them it's the only issue in life. Now, you can have disruption caused by technology. You can also get productive disruption through better management change, and we need that in mental health. A switch to prevention, an emphasis on recovery, to having stepped care, that is a system that covers all the different dimensions of mental health from mild to serious, and through making it more localised by putting more people out into rural and regional and into poor areas.
But Alan, what about this challenge of putting the person at the centre, not just in a token way, which is really, and that's across the system, not just in mental health?
Well, I believe there are 2 or 3 ways of doing that. Have the person in charge of the spending so that the provider knows that the consumer can switch.
So like the National Disability Insurance Scheme?
Like the Disability Insurance Scheme. Have more information, like publish the records of hospitals, their performance, and also, in some cases, give the consumer more technology and other access to information.
Leanne Wells, you run the Consumers Health Forum of Australia, it's our peak body in consumerism. How much of a job is there to do to put the consumer at the centre?
I think we've got a long way to go, Norman. And really, I mean, what I welcome about the discussion today is the opportunity to learn and translate some of the thinking and concepts from business into healthcare, organisation, governance and redesign. Because really what we're talking about here is consumer sovereignty. And it's a very unwise business, isn't it, that designs new services or chooses to disinvest in something without doing its market research and looking at need and looking at what products and developments and services are going to meet that need. So we're really looking at a paradigm shift, and I think there are shifts, you know, so the shifts around consumer-directed care, the notion of activated patients, as Alan's talking about, with access to information about performance of their services, being activated and supported to be confident, as you know, the Choosing Wisely campaign's trying to do around ask the question of your clinician about whether you need these things. I think, you know, we're on a bit of a roll here with those sorts of shifts.
Tessa Boyd-Kane, you're Deputy CEO of the Australian Council on Social Services. We have a system in Australia that Don Barrett would kill to have, because the United States is one of the few countries in the world which doesn't have a universal healthcare system. What about the voice of the people who don't necessarily have a voice?
That's right. And one of the things that we've seen in Australia is that our health system, along with other systems, has really protected us against the levels of inequality that we see in countries like the US or indeed in the UK. But at the same time, we are seeing a growing trend in inequality in Australia, and that's very much reflected in people's access to healthcare and to the health system. So one of the things we need to think about, if we're interested in putting people and communities at the heart of the system, is how do we ensure access for those people who are missing out at even the most basic level. So that includes people with chronic health conditions. It also includes people in rural, remote and regional areas. It includes Aboriginal and Torres Strait Islander populations. And most dishearteningly, it includes people on the lowest incomes. The opportunities for disruption are not just about technology, it's about the use of data and how people use data to make choices that currently the system doesn't even think of as choices, about what kind of health service they access, about how often, how regularly they use that access, and indeed whether they want that access at all.
Jeremy Sammut from the Centre for Independent Studies. Have conservative thinkers come round to universal healthcare for all?
I think we've come around to the idea that it's right for there to be universal subsidies for health, particularly for low-income groups. But the question is whether we're using those subsidies as efficiently as possible to fund current and future healthcare needs. I think we've heard today that we've got a system that is fragmented, that doesn't provide care for all those people who need it, particularly those on lower incomes, but it's costing us an increasing amount at the same time. I don't think we have a health system, let alone a health insurance system. What we have is a system of payment mechanisms for particular providers to do particular things. I think if we're truly going to have a patient-centred system, we need to put more control over health dollars into the hands of patients themselves and require providers to compete for the business of those people in order to provide people with the care they need in the lowest cost, most efficient way.
I thought it'd be good at the end to actually have Don Berwick ringing in our ears, and I asked him what would happen if nothing happened.
If we don't do something, healthcare will continue to confiscate opportunities from other elements of society. Social justice will suffer. Your roads and your schools will suffer. Your corporate competitiveness will suffer. Laborers will see less money. You're going to feel a sense of scarcity because healthcare is taking so much. And in return for that, you're not going to get the health you should have. You'll be a less long-lived, less robust community. All of that's unnecessary. We know what the care system could look like if you have the guts to get there. And we know how much you could give back to society for other uses. So the stakes are high. The stakes are, do you want to be not just a good healthcare system, but a healthy nation in the broadest possible sense, a nation of well-being. And if without redesign of care, we put up a barrier to that we probably won't be able to cross. If you decide to do it and come together as communities to do it, exercise the courage needed and overcome the political obstacles. A part of this is political. Yeah, you can have well-being at a level that we don't even dare imagine today.
Professor Dawn Berwick. Catherine Livingstone, I'll give you the last word.
I'd really like to pick up on that last comment of Dawn's. We've been talking about a health system, but actually all of the conversation has been about patients, unhealth, sickness. Actually, the health system is the whole country, and we're going to put consumers at the centre. Consumers also have a responsibility to stay as healthy and be as healthy so that the system, when they get sick, can be focused on those aspects which are not preventable. So getting a focus on the first 50 years of life and keeping people healthy versus the second 50 years and fixing them when they're sick. That's a mindset change for the country, not just the health system.
And that's where we must leave it. It's very important that we as a community join in this debate, because if we don't, things will be done for us and to us rather than with us. So take part. I'm Norman Swan. Bye for now.